welcome to the Hammersmith Hospital. My name's Rasha Al-Lamee and I'm an interventional cardiologist. I'm joined here today by my two friends and colleagues, Sukhjinder Nijjer and Sayan, and also by Chandra and Cecile, who'll be helping us as part of the team, and our two fellows, Chris Rajkumar and Mike Foley, who'll be presenting the case and assisting us as we go through. So today we have hopefully a very interesting case of IVUS and physiology guided angioplasty to a right coronary artery, and we're going to present this case. We're in our brand new Azurion lab here at the Hammersmith Hospital, which literally went live a week ago, and we're going to be showcasing some new physiology technology in the form of the OmniWire by Philips. So I think we'll start by Mike Foley presenting this case for us, and then we'll hopefully go into discussion.
Lovely, thank you, Rasha. Thank you, Sayan. Thank you, Sukh. So I'm going to be presenting the background to this case, which is obviously from Imperial College Healthcare NHS Trust, and we're presenting a physiology case today. So this is the case of a 58-year-old man, and I'll go through his background initially. He has an established diagnosis of type 2 diabetes with an HbA1c in January of this year of 57. He's also hypertensive and has high cholesterol, with a relatively well-controlled LDL of 1.46 in January of this year. He also has a history of a right thalamic infarction in 2020, which has left him with a mild left-sided residual weakness. So his index presentation to this hospital was in December of 2020 with chest pain, anterior biphasic T waves, and he had a dynamic troponin going from 14 to 1400. Bedside echocardiography at the time showed normal left ventricular systolic function, no significant valve disease, and no regional wall motion abnormalities. And he then went on to have an urgent inpatient coronary angiogram. We'll look at those pictures in more detail in a moment, but it showed a patent left main stem. It showed a severely diseased LAD from the mid-vessel back to the ostium, which was thought to be the culprit at the time. He had an occluded circumflex with collaterals from the right coronary artery, and he had a dominant and severely diseased right coronary artery with disease again coming from the mid-vessel back towards the ostium. And at the time, he underwent PCI to the LAD, which was IVUS guided with a 3538 Onyx stent. So he was discharged and then followed up in clinic, where he reported some shortness of breath on exertion, and his outpatient cardiac MRI showed good LV systolic function with viability in all territories. He had a small partial thickness infarction in the infralateral wall, and he had limited subendocardial perfusion defect in the infraseptum. These are his medications. You can see he's on dual antiplatelet therapy. He's on atorvastatin 80 milligrams, an SGLT2 inhibitor. He's also on 2 anti-anginals, amlodipine and bisoprolol, with some other non-cardiac medications as well. So this is his angiography from his index case in December. Here we can see the severely diseased right coronary artery. And we can see this disease in the mid-vessel coming back towards the proximal vessel as well. And here in the left system, we could see an occluded circumflex with obviously some severe disease in the LAD as well, which was thought to be the culprit in the course of his presentation. He went on to have PCI to the LAD, and I've just truncated the PCI shots here for these purposes, but we can see that he went on to have a very nice result in the LAD. So he's coming back today for physiology and IVUS-guided staged PCI to the RCA in the context of a recent ACS, and he might go on to have symptom-guided management of his circumflex CTO. Thank you.
Okay. Thank you very much for presenting the case, Mike. We're just going to talk to you a little bit about where we are now. So we've obviously got this patient back on the cath lab table. We have right radial artery access, and we've taken some repeat images just to see where we are today. So if we go through those images, so you can see hopefully here from the left coronary system, which we just imaged with diagnostic catheter, that we still have this proximal CTO of the circumflex artery, and it appears to be a co-dominant system. If we go forward, we can see that LAD stent is very nice angiographically. There's some mild diffuse disease distally, but really nothing much else in the LAD. If we keep going forward, and again, very nice result there on the LAD. And then if we go on to the right coronary artery images, what we found immediately actually on intubation of the right coronary catheter was that there was a pressure dampening in the ostium. We can tell that there's a significant osteal lesion there, and then also moderate to severe mid-vessel right coronary lesion, and then obviously some more diffuse disease distally with some backfilling and some collateral flow back into that circumflex artery. Keep going. And again, here you can really appreciate that severe osteal lesion. And keep going. And then perhaps that mid-vessel lesion looks a bit more significant there. And it looks very much like we have two quite tight angiographic stenosis here with some moderate disease in between. Sukh, did you have any thoughts to add here?
Rasha, this is a great case. This is going to bring up lots of questions from the audience and those watching from the panel. And I think it's a great one to showcase the technology. This is a tricky looking right coronary artery with quite severe disease, and it'll demonstrate that we can use pressure wire technology now to localize where we perform our intervention. So we're moving away from should we to how do we actually perform the intervention, and we'll be able to show you both road mapping technology, co-registration, and do it all in a brand new cath lab that has very low radiation. So I think this is going to be a good case for the audience.
Yeah. And Shai, when you see a CTO in a kind of collateral vessel, what do you worry about that, bystander CTO disease in the context of physiology?
Yeah, absolutely. I think we know from both resting indices and hyperemic indices that the contralateral obstructed artery will have an effect on the donor vessel. Now, usually the effect is small, and once we've done physiology pre and post CTO opening, we see that there is effect, but it is small. So I think if you have moderate disease, yes, certainly it would be something that would play in my mind, should I be stenting this without opening the CTO? But this is not moderate disease.
Yeah.
So I think, as you said before, we're not using this to tell us if we need to stent this vessel.
Yeah.
We're going to hopefully demonstrate how we use physiology to guide our intervention.
Perfect. And so just to sort of, because we had this problem obviously with the pressure dampening, what you will see on our setup today is that we already have a Sayan wire just as a coronary wire just there to kind of hold the catheter in place so that we can do our physiology without worrying about pressure dampening as we advance our pressure wire. Shai, maybe you could talk us through the new OmniWire and the setup stages.
Fantastic. So the OmniWire is a new technology that's come out from Philips. It's a next iteration of pressure wire, which has some unique features. You can see it's set up very similarly to how their previous versions of their pressure wire have been set up. So I'll go through the steps with you, and then we'll talk about some of the unique features of this wire. So the first aspect is to flush the wire. This will activate the sensor. And historically limit any drift, but we'll see and we'll discuss why this wire is unique in that drift is very, very low. They've really labelled it very nicely for interventional cardiologists in a very simple 1, 2, 3 manner. And so we flushed already, which is number 1, and we're going to take out the connector, which is number 2. And you can see here the connector is slightly differently shaped from previous versions of this technology. And all we're going to do now at this stage, without touching anything else, is connect this up to our permit.
And Shai, just while we're going through the process of setup, could you talk us through why it's so important to do this correctly at the beginning of a physiology case? You've taken the time to set this up flat on the table, you're flushing it, and you're connecting it in a very systematic way. Why is that really important?
I think you're making decisions on pretty small margins when it comes to physiology. There's a defined cut point, and I think you've got to make sure that you've zeroed the wire and prepared the wire appropriately. You've got set yourself up for success with physiology. Okay, if you do the early steps correctly, you're going to get a robust answer that you can kind of hang your coat on and do your intervention on the basis of. If you don't do these steps early on, you'll see that you may be prone to more drift, you may be prone to more variation in the results, and therefore you'll lose confidence in the technology.
Absolutely, and it's very common for cath labs to ask a junior member of the team or perhaps a member of the nursing team to set this up, and it's worth watching how they do it so they know the best optimal ways of doing it to avoid these issues.
Absolutely. So I think we're zeroed there, and the system will tell you that it's set up and ready to go. So what the next steps are, we're going to take this out. Step number 3, which is going to demonstrate the back end of this wire, which is unique. So Rasha, I'm going to pass you the the wire to support in a second.
So maybe we could go through what's new about this wire versus our previous iterations of the pressure wires.
Okay, so most pressure wires, in fact, all the other pressure wires have a hypo tube in the center, which generally takes the cabling from the sensor all the way to the permit. This is unique in that it is a solid core, nitinol core, which allows it to behave far more like a workhorse wire, which Rasha will demonstrate shortly. The technology is so advanced that essentially the information from the sensor, which is incorporated into the wire, is passed through what is called ribbon technology around the surface of the wire back to the connector and the permit. In addition to all of that, the back end of this wire is so intuitive to use. You've got a dedicated talker that comes with a wire, but the back end, as Rash is passing this through, I'll demonstrate to you, is extremely robust. And this is cobalt cabling, which allows us to be quite robust, do quite a lot of intervention on the wire, and hopefully we'll be able to demonstrate today that is without any detriment to its pressure wire capability.
We're just going to start now in terms of taking measurements. So the first thing to say is that we always give at least 300 micrograms of nitrate into the coronary artery, which I'm just giving now. And then if you could just flush for us.
And Rasha, can I ask what the importance of nitrate?
Yeah, so it's really important that you very much want myocardial stability, and you want to minimize the amount of vessel spasm that might be there in order to make sure that these measurements that we make are reproducible and also accurate and really reflect the stenosis that's there. So now.
And when you're giving nitrates, some members of the audience may be worried about inducing hyperemia. What's your experience been about that?
Yeah, so certainly introduction of anything, whether it's saline or nitrate, will definitely create transient hyperemia. What we do is obviously we flush very adequately and then we wait. And usually within 10 to 15 seconds, you will see that the effect of hyperemia wears off and that you're kind of happy at that point to make a measurement. Of course, if you've given adenosine, you might want to wait a bit longer, but usually after nitrate or saline, it won't take too long. Okay, so I'm just...
So actually, this is a really good example of how you can manage an osteal lesion here. So why don't you take us through maybe another couple of tips and tricks you could do with osteal lesions before we look at the pressure trial.
So one of the real issues with osteal lesions is always where do you normalise? And there's a few options. One is that you could normalise out in the aorta and avoid that osteal lesion altogether. The other option is that you could take a buddy wire, which is what we've done here, to stabilise the whole system so that you can back out that guiding catheter and therefore normalise just outside of the vessel and proximal to that osteal lesion, making sure that obviously the transition between the radiopaque and the translucent element of the wire are back and proximal to that osteal lesion. And that's just what I'm going to try and confirm here. I can see that occasionally I'm still getting a bit of dampening. So I'm just kind of pulling back that coronary catheter, and then you can see that it's right the way back now. And sorry, Shai, if you could just demonstrate that. Yeah, and we can see that we're quite far back now. And in fact, probably that guiding catheter dives in quite a lot and sort of really gives us the impression that the lesion is very osteal, but in fact you can see actually that it's not as far back.
So,
okay.
Rasha, I'd like to ask you a couple of questions based on what you just said.
Yeah.
One is often we get asked about side hole catheters in this situation for osteal lesions. Can you comment on that? And then maybe we can talk about what you're looking for in the pressure trace when we're normalising.
Yeah, so side hole catheters are a great cheat. They make us feel better in terms of, as operators, but they certainly don't actually give us an accurate measurement of the intracoronary pressure that we're measuring. So I would not use side hole catheters. Yes, they will give you the impression that there's no pressure dampening there, but in fact it will be there and it will affect your physiological measurement. In terms of what we're looking for normalization, Sarah, if you could just, that's great. So what we're going to do now is if we press normalize outside.
One sec, just talk about what we're looking at.
We're going to look at a few things. So we're going to look for three aspects really, that the PDPA is 1, that the distal trace and the proximal trace, the yellow and the red, are nicely overlapped with no time lag between them, which is actually very, very uncommon these days with the new technology. and also that we've got a nice aortic morphology so that we can see an anacrotic notch, a dicrotic notch, and a rapid ascent and descent of the pressure and a nice aortic morphology there. And hopefully we can see all three of those things. Now, one thing that we always do here is we record that. So if we could just record just a few beats of this, we just record that our normalization is adequate, and we do that usually just on the FFR mode.
Do you want me to do that
and
here?
You can see here we're just recording a little bit, and we got really into the habit of doing that with the various research trials that we do, because we always try and make sure that we record that spot. We also record on fluoro where we did the normalization, and that's what we've just done. And then we're kind of in the right place now to go distally. So this is kind of an exciting day today, because this is actually the first case of OmniWire in Europe. And obviously we're just about to pass this wire and kind of see how it works. We've all had a go at bench test modeling and had a go at trying this out on models, but obviously we're doing this for the first time. So we are also here in our brand new Azurion lab, and we're going to demonstrate some key features to that. And you can see that Sukh at the end of the table is ready to show us that, because what we have is a nice tabletop display that allows us as operators to operate everything from within the lab. For the purposes of this live case, we've got a number of us here, so we're all going to do various bits of this, but you could theoretically as an operator do it all yourself.
Thanks, Rasha. So this console is a really useful way for operators to be able to perform their measurements, drive the physiology and the intravascular imaging very easily without having to rely on technicians or fellows outside of the room. This can be connected close to the patient or at the end, as it is in this particular lab, and it allows us to be able to do the normalization, perform the pullback measurements, and make all of our physiology and intravascular imaging measurements all in one go. We simply cover it with a sterile cover, and then wearing sterile gloves, the operator can do this without any issue. And really, I think that speeds up your workflow whenever you're using this technology.
The real key to this wire is that it really should behave like any workhorse wire.
It looks like it's got one-to-one torque there, actually.
And it really does have a nice torque, actually, and it's in fact finding every little branch. Let's give this a test.
So whilst Rash is passing this wire down, why don't you take us through how we used IntraSight during COVID in the way that we isolated in the lab, couldn't go outside to analyse our images. How did you find? Did it add to your ability during that pandemic?
Yeah, that's a great question, Shai. So as many operators across Europe and around the world will have experienced, during COVID, there's a huge amount of restrictions. You will have been working in labs that were isolated, separated from the rest of the team, and therefore being able to make measurements and assessment of your vessels in the lab without having to come in and out and potentially take infection outside of the lab environment was a huge boon and made our workflows very quick. And once you get used to using this technology, which on the learning curve is very straightforward, then you'll find that it's very hard to go back.
Okay, brilliant. So we're distal.
We're obviously distal now. We've put that past that wire distal.
How far distal do you normally go?
And yeah, so normally we go at least 3 vessel diameters distal to the most distal lesion that we want to assess, just to make sure that we have nice laminar flow and recovery of any of that kind of turbulence that you would have within a lesion and just after the lesion. And so I think I'm distal enough probably at this point here. And so I think I'd be happy at this stage for us to perform. We might just flush again, shall we? Just to flush the system. We usually just do this just to make sure that there's no contrast in the line and that we're still happy.
Disengage the catheter, is it?
Yeah, and then one more aspect is just obviously because we know that there were some issues with pressure dampening, just to make sure that catheter is wide out, which it is, because of course that can certainly cause a problem in terms of drop of a PA pressure and therefore underestimation of the lesion significance. Okay, so why don't we perform IFR there?
Okay, so I'm using the IntraSight device here, and we can perform a spot IFR measurement simply by tapping a button on the screen, and it will give us a recording. We can then save the frame simply by tapping again and return to a live view very easily. If we wanted to do a pullback, then that's something that we can perform without any issue as well.
Okay, so this is kind of an interesting number. I was thinking we would have a much more significant IFR at this stage.
Absolutely.
What do you think, Shah?
I agree. And I think maybe perhaps, remember the diagnostic images that we took were at the time of a STEMI, so there could have been a lot of adrenaline in the system, and there's certainly a lot of spasm. I wonder if it's worth now just taking a picture. Now we've given it a lot of nitrates. The anatomy may also look different here. Let's take a picture. Okay.
And it certainly does, doesn't it?
It does look like the vessel's larger.
Let me try and get that catheter engaged a little bit more, and we take that image again. Yep, okay. So we can see that the osteal lesion that we thought we had earlier was actually not so osteal. It was probably that catheter had really dived into the vessel and touched that first proximal lesion, which still looks relatively significant angiographically, I would say. I suppose the other thing just to say is that we need to do a drift check here, because a little bit of drift in the context of something right there at the cut point may well change our whether or not we cross the treatment threshold. So should we start by perhaps doing that?
Should we go
perhaps
into a
we could
pullback
do that while with pullback at the same time, and demonstrate how we use pullback in this case.
Good afternoon, dear colleagues, and welcome to this tips and tricks session as part of EuroPCR 2021. Thank you so much to the organisers for their kind invitation to us to speak. And thanks also to Philips for their support for this session. I'm Dr. Sukhjinder Nijjer. I'm an interventional cardiologist working in London, and I'm joined by several dear colleagues, some of who you've seen on the video already. Joining us today, we have Professor Nick Curzen, who is the president of the British Cardiovascular Intervention Society. Welcome, Nick. Nick is well known to many of you and has been a pioneer in the space of physiology. We're also joined by the two operators in this case, Dr. Rasha Al-Lamee, who will be familiar to many as the lead and driver of the Orbiter study and has really altered the way we have practiced in the last few years, and also to Dr. Sayan, who's a director of the catheter labs at Imperial College and the Hammersmith Hospital. So we have seen this has been an interesting case, and I have tried responding to some of the questions that have come through on the chat. I'm going to put some of these questions to our panel, but why don't we take some of the views of our panelists now? I'll perhaps go to Professor Curzen first, as he is seeing this for the first time, and to see what his feelings are having seen this first part of the video.
Well, thanks, Suk, and again, I would also like to thank the organisers for the invitation. I suppose starting, going back to the whole, reviewing the whole case from the beginning, I guess there is an argument actually that the case should have been offered for surgery, and I think we have to go through that discussion because I'm sure a lot of people in the audience will be thinking that he is diabetic and he has got multivessel disease. We have a wealth of data from both randomized and observational studies suggesting that a patient in that position, if everything else is equal, will do better in the long term with surgery, and they will do better with mortality advantage, which is unusual in revas world at the moment. I think that is an important observation. It may well be that he was offered a choice of surgery or PCI at the time of the index, but the end STEMI wouldn't have put me off discussing him with a surgeon and discussing that option with him. In terms of multivessel disease, whether or not you've got diabetes, PCI versus CABG, we also have the Syntax's 10-year outcome, which also suggests a mortality advantage for surgery versus multivessel PCI. So certainly going back to the beginning, I think it's important to register that this patient would have been a candidate for a discussion about surgery, and you may well have had that without that being presented. If we move past that very important consideration, I think this is a beautiful case because One of the things that we know very well from multivessel physiology is that it tends to change cases that have angiographically three-vessel disease to more commonly either double, single, or no vessel disease. And that's been, again, documented very well in a whole series of mainly observational studies, but of course in a lot of the original very important randomized FFR studies. And that's a very important observation. So if you see someone with multivessel disease, measuring physiology in all the main vessels may well change them from functionally to functionally 2 or 1 or even 0 vessel disease, even if they've got anatomically 3 vessel disease. And we've seen that in a huge range of studies, including, for example, the functional syntax score. So it is no surprise if we review all of those studies to find that this right coronary actually is negative for ischemia. And in some ways, I got the idea that maybe the operators were definitely not expecting it to be negative, but that's the whole point. It is negative, and it's been done meticulously. The very important point that Rasha made just before we stopped about checking for drift when you get a result that you don't expect. Well, Rod Stables and I did a randomized trial of 2 different types of pressure wire, and we put 2 wires down and measured a lot of vessels with 2 wires simultaneously to compare performance. And it is very, very important that you know what drift is, even if you've got a new wire in your hands where the drift is apparently much less than it can be in other wires. It's still, when you get a surprising result, important. The other little point I'd make before I shut up is that I think it is important, if you're cross-filling a very big territory, to take that into account. Specifically, it's not going to be a wrong measurement, but there is a possibility it will take into account the area of myocardium supplied by the cross-filled vessel. And so you may get a more significant reading in the donor vessel than you would have done if you'd reopened the occluded vessel first. And that is something important. In this case, the measurement is negative, but the first thing I would do is what Rasha said, which is probably pull the wire back, re-equalize, re-normalize, and then put it back down again to check the measurement, and maybe take a different type of measurement as well, just to be absolutely sure.
Okay, well, that's very clear, Nick. Thank you very much. So we've got some questions from the audience, some of which you have already addressed. So perhaps we should ask our 2 operators. Shai, you were the consultant involved in the care of this patient and responsible for the patient, and you were involved, as I understand it, in the original case. Was an MDT something that was considered? Was surgery something that was on the table for this patient?
Yeah, so it's a very good point, and we have quite a robust MDT process at Imperial. This is an hour-to-hours presentation with a chap who's having ongoing stuttering chest pain. So rather than convene a full MDT, it was a telephone call to the on-call surgeon to discuss a gentleman with, I think if he was stable disease, for sure he'd be off the table and listed for surgery, but taking a patient with ongoing stuttering chest pain, an acute looking LAD for emergency bypass is a slightly different beast to a stable patient. So we had the discussion, and it was advised that we get him out of trouble and address the LAD.
Okay. And look, if I might add, I think that's a very important response. So it was considered, a surgeon was involved. The experience is frequently, when someone does have ongoing pain and evidence of ongoing ischemia, that even if your surgical colleagues agree to take the patient on, we are in danger of getting into a loop which becomes extremely frustrating, and we have to be wary of. And that loop involves them saying, we'll do an urgent operation possibly tomorrow morning. Can you put a balloon pump in? And then when the patient has gone back to high care or wherever your hospital looks after patients with balloon pumps, they have ongoing pain. And then when you ring the surgeon and say they're having ongoing pain, they say, well, their troponins gone up, so we want to settle them down. And so we have to be very, very careful in this particular context that we don't put our patient in a position where they end up with a balloon pump that you wouldn't have normally used. And then you have to take them back under even more urgent circumstances to do the revas that you could have done there and then. So knowing your surgeons and knowing the way they work is very important when you're having a discussion if they've got active ischemia.
Okay, so we've got a few important questions that are coming through from those watching online, and I'd like to put them to the panel. There was a question about the impact of CTOs, and Nick, you've already touched on that already. And just to summarize, your principal point is, of course, if you have a vessel that's a donor vessel to the CTO, then that will artificially have increased flow velocities across that vessel, and therefore your IFR or FFR values may well be artificially positive, and opening the CTO may resolve that issue, and therefore it would be worth opening the CTO. Now, in this case, the IFR is negative, so that's somewhat less of a concern. And there's another question that perhaps we can ask the team is what they think about this in relation to the recent Flower MI study that was presented just at the weekend at ACC, and how that relates to this particular case.
I mean, the first thing I would say, Suk, is I completely agree with everything you said, except I wouldn't probably go with the word artificial, because the physiology is the physiology. So what you're measuring is real, and it occurs because the area of myocardium that's subtended by the vessel that you're measuring the physiology in is much bigger than just that vessel's myocardium. So the physiology you measure at that point is genuine. It's just that it's for a reason. And if you were to reopen the CTO, you might well find that the physiology is negative.
Okay, so I'm just being told, sorry, Nick, that in the interest of time that we should continue on with the rest of the video. I'm sure we'll get a further discussion going on here. So is that okay if we should move on to the next component, please?
Right, so we're going to do this pullback actually on co-registration. So we're going to start by making sure that we program continuous fluoro. And we're also just going to make sure that we've got all our shots set up. So what we need to make sure is that the guide catheter is in view and that the distal wire tip is also in view of this OmniWire. Okay, and then what we're going to do is we're going to start by doing fluoro and a continuous pullback where we pull back the wire really as we would an IVUS catheter, just very slowly, 1 to 2 millimeters per second. First, I wait for everything to be flat. And then on continuous fluoro, I'm just going to pull back. Now it's interesting because of course there's a buddy wire here, so I'm hoping that the system will recognize which wire is moving and which wire is static and stays throughout the frame. Okay, we'll stop there. And then what we need to do now is do an angiogram image. So we'll stop the recording. Do an angiogram image. And then hopefully we're going to see some co-registered physiology images there. Interesting. So the physiology would tell us here that all of that pressure loss is really in the proximal lesion. What do you think, Shai?
Interesting. The other thing it's told us is that you can safely do this with two wires in. It hasn't
yes,
taken away.
that's absolutely true.
The OmniWire on the pullback, which means the technology is robust.
Okay, and we're back for some further discussion. So the video has shown that you performed a pullback, and I think you see a couple of interesting points. You see that there is no significant drift, and therefore we can rely on the value. We can see that there is a pressure step in relation to the angiographic lesion. And so along with our eyes, there is definitely pressure loss, although it does not reach the significant level. And if this patient had been randomized into a defined flare or IFR sweetheart, they would have deferral of their intervention. Rasha, what are your thoughts at this moment in the case? What are you thinking of doing?
Yeah, so I mean, we've had a lot of discussion, obviously, about the complexity and the kind of nuances of this case, but actually this case, I think, does illustrate the sort of things that happen in clinical practice. So we unfortunately didn't see the angiographic co-registered images there, but hopefully we'll see that on the next slide. But what you will hopefully see is there's some pressure loss within that lesion that we saw in the proximal vessel, but ultimately it's a very diffusely diseased vessel that certainly doesn't cross the threshold for treatment in terms of IFR. So I think, as Nick mentioned earlier, a reasonable thing at this stage is to consider other technologies, and an FFR assessment will be reasonable. When you're in a situation where you're scratching your head, the best thing you can do, I think, is give yourself more information and more of an opportunity to try and put everything that you know together to make a picture. And it may be that you change your decision based on another assessment. It may also be that it just adds to the confidence in the technology you've used.
Okay, and did any of the other team have any comments they would like to make?
I would definitely also measure FFR in this case, because sometimes there is a discrepancy between them. And I think, regardless of the fact this is negative, it makes an extremely important point, which is if you measure physiology in vessels that have any atheroma at all, you will be wrong about the functional significance if you just base your judgment on the angiogram in about 30% of the lesions. And that's been shown in more than 10 sets of different populations of vessels and lesions. So you will be wrong, your prediction will be wrong in about 1 in 3. And this is a perfect example. We all probably would have guessed that this was going to be physiologically significant, and it is not based on these measurements. That's why physiology is very important when you're trying to decide where to revascularize, particularly with PCI. Of course, the irony is if the patient hadn't been unstable and they had been offered up for surgery, they would have got a graft on this right coronary, definitely. And we don't know whether that would have been an important graft or a bit of a waste of time. There's some evidence, although it's not particularly strong, that if you do put a vein graft on a vessel that is pressure wire negative, then the vein graft has a much higher rate of failure early. And certainly I wouldn't want to put an arterial graft on a vessel that's pressure wire negative for that reason. But of course, lots and lots of bypass surgery patients presumably have vessels bypassed that are physiologically negative. In the ESC, we're hoping to present as a late-breaking trial the Ripcord 2 trial, which was a trial of stable patients. One half had angiographic assessment, and the other half had a full assessment of pressure wire of every vessel of graftable or stentable diameter. So we'll see in that trial whether a routine pressure wire assessment of everything has an advantage or not.
Okay, thanks, Nick. That's very helpful. Shall we resume our case to see if there are any changes in our decision-making over the next few minutes?
You've shown how easy it is to perform a pullback, and we can see that we have a borderline IFR value, and there is clear, distinct step related to where the lesion is. We saw that when we were watching the IFR trace live, and now we performed a co-registration to try and marry the two pieces of information up. What we can do is to interact with that display to remove lesions and therefore predict what our post-PCI physiology would be.
Here we are with an IFR that's very negative. I guess the question now is, what would we find if we did FFR? So we've got intracoronary adenosine, and we're going to just inject 120 micrograms of intracoronary adenosine and see what we find and see whether the FFR is any different. So Suk, you're ready for us here on the FFR mode?
Yeah, absolutely. So what I'm going to do, I've got complete control of the system. I can go back over to the pressure wire. I switch over to FFR. That starts recording straight away and then allows you to be able to give your injection. Obviously, when you give an intracoronary injection, the port is opened, and that can give artificial values. So it's recording at any time you're ready.
Yeah.
And then we can just adjust that.
Okay, yeah. So I'm ready when you are. So
you're going to flush through when
yeah, I will.
Okay, so I'm just injecting now the adenosine. Okay, and then if we flush.
Okay, flushing performed now.
Yep, and then we can.
And that's enough flush.
And we're obviously recording already.
And so you have to ignore the value that's up on the top of the screen, because that's going to be artifactually affected by the flush and the port being opened. But then you've got a period of consistent values there.
So I think here it's steady, and it's 0.81, 0.80.
Okay. So we've got a very nice value here. If you look at the PDPA value there, so if I press stop, and then I can move this to where we think it's most steady, and then we can see that in this zone here, where we've got a nice steady trace, most of the values are bordering along the 0.8 to 0.82 values here, very consistent. And so we can relocate the FFR there simply by pressing that, press accept, and then we've got a borderline IFR value as well as a borderline FFR value.
Okay, fine. So I think we will obviously repeat the drift check now. Be happy that there has been no element of drift here, and then maybe we should have a conversation about what we do next. So I'm just bringing back the wire. Obviously, it's not pull back at this stage. It doesn't need to be particularly slow. Just bringing it back to the same position up by the catheter. And we can see that there is no drift there. Very happy with that. We could flush just to check as well.
Okay.
But and then obviously we just wait for the hyperemia to wear off. And then I'm pretty happy that this wire has not drifted. If we go on FFR mode, we just record that. And again, we always just floor record just to make sure that we've stored that. So we've got an IFR of very borderline, 0.92, 0.93. We have an FFR that was also very borderline at 0.82 in the context of a kind of co-dominant system with a CTO of the circumflex, and in a patient who's had some breathlessness and some ischemia on an MRI. This is the classic kind of case that we see all the time and often get asked about, what do you do with these cases? So what do you guys think? What next?
So I think that the borderline traces in the context of a contralateral CTO, you'd expect it to be more positive.
Yeah.
So if we could imagine that we've opened up the circumflex, you could arguably say that the right coronary artery is going to become even less physiologically significant.
Yeah. As you remove that steel that would otherwise be going, and the flow towards the circumflex.
Absolutely. And so we do know now from over 15 years of work with FFR and more latterly IFR that with both these values, the patient's on safe ground. Mm-hmm. Okay, so I would favour pausing at this stage. His symptoms were a shortness of breath on exertion. Lots of other things could be doing that.
Yeah.
And I would look to review him in an outpatient setting to see how his symptoms are.
Yeah. Now, so, I think that's absolutely right. It's a shame. We wanted to be able to stent something today and show IVUS and stuff. But hopefully, I think what we've shown is that this was an angiographically tight lesion. I think we'd have all predicted that we should be stenting this. And actually, we only wanted to use physiology to guide where we were going to stent. And now we've all been kind of surprised that we don't need to stent at all. But for the patient, that probably avoids, potential procedural complications now, late complications as a result of more stents. And ultimately, what we know from lots of the evidence that's out there is, more stents aren't necessarily good for you. You just need the right stents in the right places. So I suppose there's some other comments to make. We've obviously used a buddy wire here. The purpose of this new OmniWire is really to be used as your main wire, the wire that you would stent on, and then you wouldn't normally have to have another wire alongside, but of course we've done that in this case. Any other thoughts from you guys? Anything you think that we need to bring out in terms of the discussion of this case?
Well, Rasha, I think this is a really instructive case. We often get asked whether you would use pressure wires in severe lesions, and traditionally many operators across the world have reserved it only for moderate lesions. And I think many of us would agree that this is angiographically quite significant. However, we can see both using resting index and a hyperemic index that there is no significant ischemia. And if this patient had been randomized into either defined flare or into the FAME studies and had FFR, that they would not have had intervention. So I think it's right to medically manage in the first instance. Of course, things change over time and we may alter our treatment. And in case, it may be worth tackling the CTO and considering the change depending on what the patient's scenario is. But in a gentleman without significant symptoms, without significant ischemia, then it would be reasonable to medically manage. And I think this demonstrates yet again that we should be using pressure wire in more cases than we already do.
Yeah. Shai, any final thoughts from you?
Yeah, absolutely. I think the more and more three of us have used pressure wires, the lower our threshold is to take that pressure wire to guide our intervention. You're absolutely correct. We'd have to put quite a sizable stent in here, and we're committing him to PCI of the right coronary artery when the myocardium doesn't need it. And so we do have a lot of data to say we are safe to stop. Doesn't mean that he doesn't come back in the future, perhaps, for an intervention should his symptoms change, but we know that we're on safe ground to stop.
Fair enough. So why don't we I'll just take some final images now.
No, you don't need it now.
Wow.
Okay, all right.
Okay, and then maybe one from the other side. But yeah, I mean, we'd have all put our money on that being positive. And then if we take one RAO image, just to check we haven't done any damage. And there we go. All right, so we've left it really as it was.
Well, that was a really interesting case. We've had a look at this patient that's had a fairly complex history over the last few months. He's had a myocardial infarction that affected his LAD, and that's been stented. And then since that time, he's actually doing pretty well, not much in the way of symptoms. He then went on to have a cardiac MRI that showed relatively limited changes in ischemia with viability in all the territories. And then because we knew he had fairly complex disease involving the circumflex and the right coronary artery, we felt that we should bring him back to the cath lab. So, Rasha, we wanted to take a look at these vessels, and the RCA looked like it had a severe angiographic stenosis, and we wanted to assess that using physiology. What did we find?
Yeah, so I think this is an incredibly interesting case, the sort of case that we see clinically all the time, or often get asked about. And, you know, people are often saying, what do you do in these cases where you see something angiographically and then you're quite surprised with the physiological result? So I think today we've demonstrated a few things. One, that it is actually really important not to just rely on your eyes and to try and assess for ischemia. We know that from the MRI there was kind of borderline ischemia there, but certainly not a large segment of ischemic territory. So I think the physiology was really important. We went in expecting that the physiology would only guide our approach as opposed to change our approach, but it did change our approach entirely. And I think it's very tricky when you have borderline IFR and FFR values to proceed just to go on what you saw and to stent that lesion, and that would be the wrong thing to do in my view. I think also we had that the collaterals towards the CTO that kind of added to the complexity of the case, and really made me start to think that if the CTO was to be fixed, that in fact the IFR and the FFR values would only go up rather than down, and be less positive, more negative, and guide us even more towards a strategy of conservative therapy for that RCA. So obviously we stopped. And I think that's the right thing to do. We bring that patient back to clinic, we see how they're doing, and then we decide in future if anything needs to change. I guess in terms of some things that we learnt today, you obviously demonstrated the new Azurion lab and the ability to use that tabletop display, which actually, as we get more used to it, of course it's been the first week, I think we as operators will be using all the time ourselves and will not require a second person to touch the screen. How did you find that using that?
I find it incredibly useful. I think the advancements of the Azurion lab in terms of radiation dose and the image quality is fantastic. I think having the IntraSight and having the ability to manipulate the IVUS and coronary physiology by the operator without relying on somebody else being able to drive it, I think is an absolute huge development and boon. And I think it really speeds up your work when you're doing it. You're not having to shout out to somebody in the control room of where you want the dots placed for intravascular imaging. I think that's something that many interventionists across the world will recognize the frustration of that. And when you're making a sync vision assessment, for example, for interrogating where you're going to place your stents and trying to predict your physiology, you can map that out yourself using the joysticks. So I think there's a real utility in that. And it certainly has, I anticipate it's going to speed up our workflow here. I've had the opportunity of using it elsewhere, and I know it works wonders.
Yeah, and I suppose the key point of today really was to use the OmniWire for the first time in Europe. It's a shame we weren't able to stent the first patient who had an OmniWire put in, but actually that's the whole point of physiology, isn't it? That we work out what we need to do and where we need to do it, and we use physiology in the right way. So in a way, it's quite nice that very first OmniWire case in Europe actually entirely changed our approach. And maybe that's what we need from physiology, and that's what we've been looking for. From a handling point of view, I found it very easy to handle, very much like a workhorse wire. I obviously had that buddy wire there because of the issues with the guide catheter. in other settings, I think it would be absolutely unnecessary. I could do everything on that one wire. And from the first attempt at using the wire, I obviously found it pretty easy, but also we didn't see any drift. And that was, there was quite a length to that case and we still didn't see any drift. So that was quite nice from that point of view. And I think going forward, I think one thing we've been learning in this lab is that we basically very rarely rely on the angiogram now. I'd say 80 to 90% of our diagnostic cases, once they have disease, will have physiological assessment. This case was a little unusual because I guess he came in as an ACS patient, but certainly in the stable setting, we've been using physiology on the majority of our angiograms because we know that the eye very often tricks us and makes us want to overtreat things.
I think you're absolutely right, Rasha. I think there's so many different things to unpack there. In terms of the utility of the wire, I can see that it handled very nicely. You were able to bring it back and forth in the vessel. I appreciate that you had a buddy in this particular case, but I don't think that would have altered things dramatically. And you were able to pass the wire back and forth without any issue. And so that's great. And I think that will hopefully solve many of the concerns that many operators have about how easy it is to use these pressure wires. And then that fits really into how we view these technologies, is that we think of them as diagnostic technologies. And certainly here in our particular lab, where patients typically with stable disease will have an invasive coronary angiogram as a diagnostic procedure, we will perform a pressure wire at that time. And so we will then know whether the patient has ischemia based on a pressure wire assessment, and we can map out that ischemia and work out our strategy. And that allows us the opportunity to discuss intervention with the patient if that's appropriate, or
Okay, so I thought I was talking for too long, so I thought we'd get the panelists to talk instead. I'm going to cut myself off, if you give me permission, and let's see what our colleagues have to say about this case. Rasha, why don't you provide us your principal take-home messages from this particular case?
I think I probably did that at length during the video already, but I mean, I think in reality, what we've seen today is even those of us who physiology a lot and have already learned physiology very often changes our management strategy, still can be surprised. And that's the need for us to use some of these techniques in our usual everyday practice.
Nick, how would you like to summarise your?
As a case, it's really valuable because it demonstrates how meticulous you have to be to get measurements, especially when you get an outcome that you don't expect. Every time you do a pressure wire, it's like you're doing a special investigation on behalf of that patient. You have to be absolutely meticulous. You have to check it if you're not sure. You have to use all available information, and then you have to believe it. And you must not ever want to stent a lesion just because it looks like it does. Otherwise, there was no point in doing the pressure wire investigation in the first place. In this particular patient, it would have been wrong to stent this right coronary, despite what it looked like. It would have done the patient no good, and it may well have done him some harm. In the future, if he continues to get symptoms, he'll have to be reassessed. It's possible the CTO is causing ischemia, because my understanding is, although there may be a small infarct in that territory, it's still viable, and therefore it may be ischemic. And in a few months' time, when he comes back with angina, you might have to reassess the right coronary with a pressure wire because it may have changed. But as things stand now, he needs to be on optimal medical therapy, and he doesn't want to have any more stent. I think in terms of an example of how physiology can affect your management, it's a very good case. And I think as a little technical issue, when you have to back the guide off, you have to be very careful about giving intracoronary adenosine, because obviously you may not be able to give the full dose. Often you can balance it so that it is engaged enough to give the adenosine, and I think that's what Rasha did in this case. So you have to be very aware of that. If you have to back the guide off, then you probably need to give IV to be absolutely sure. But this all fits together. It's a good case, and it's a good outcome for that patient.
Okay, well, that's absolutely fantastic. So we've shown quite a lot of different things. We've got people suggesting whether we should have used imaging in this case to guide our intervention, whether this patient falls more into the complete study versus some of the other physiological studies. How do you respond to that? Would you suggest that perhaps if we treated him as a complete case, then he would have had intervention to that territory?
We wouldn't have had any right to treat him as complete because that was a trial of STEMI and this was an end STEMI. So I don't think there's any. We must be very careful we don't start getting into that game, because The STEMI physiology issue is, as we've seen in this meeting, very difficult and complex. I don't think NSTEMIs are quite the same for various reasons. So I don't think we should extrapolate from STEMI trials of physiology and complete revas to NSTEMI. They're very, very different beasts.
And Rasha, how would you respond to people suggesting maybe imaging, perhaps performing an intravascular ultrasound or optical coherence tomography? Would that alter your decision making here?
So, I mean, we didn't feel that this plaque was unstable. I think if there was a sense that this plaque was unstable, he had represented with rest pain, troponin rise, ECG changes, that might have been different. I might well have used OCT or IVUS to try and actually characterize the plaque and think about the plaque morphology beyond its ischemic contribution. However, in this patient, in which essentially what we're doing is doing a staged assessment of a patient that's been stable, what I want to know is, does this stenosis contribute to a reduction in blood supply to the heart? And I'm not going to use an anatomical tool to work that out. I'm going to use a physiological or functional tool. And I think in this case, imaging wouldn't give me any information in terms of whether or not to treat the patient, but might well have been used had we decided to treat the patient in terms of what techniques we'd have used.
Okay, well, thank you for that final comment there, Rasha. So perhaps we can summarise in saying that here in this case, we've shown the use of pressure wire technology to interrogate disease, and we have shown that even in severe stenoses based on an angiogram, your treatment strategies can be altered completely, as Nick shown in the Ripcord study, and it's been shown time and time again, and that the technologies are robust, versatile, and can be delivered easily, as well as performing the pullback and code registration. So it remains for me to thank Philips and for the audience for joining us in this session. Thank you very much.